Welcome back to the Deep Dive, the place where we turn these massive academic sacks, the dense foundational material that feels impossible to memorize, into clear, manageable, and frankly, unforgettable study sessions.
Yeah.
If you are looking at this mountain of knowledge and you're realizing it covers everything from cell science to, well, constitutional law, and you're feeling that familiar academic chill, just take a breath. We are here to guide you. We're going to offer the clarity and the structure that you need.
That's absolutely right. And you should think of us less as lecturers and more as your specialized study buddies.
Right.
Imagine we're sitting right beside you with a virtual whiteboard, ready to go. Our mission isn't just to review this stuff. It's to actually transform this complex information into, crystal clear building blocks.
Yes.
We'll be spotlighting the absolute must-know facts, framing them with context, and spotting those critical decision pathways that are going to challenge you. We want to make sure you grasp not just the what, but the deeper why behind every single concept.
And we have quite the journey ahead of us today. We are synthesizing material across 4 really massive themes.
That's a big one.
It is. First, we're going to tackle the social justice core of health. This means diving deep into disparities and the non-medical power of what we call the social determinants of health, or SDOH.
Right.
Second, we'll move into some essential clinical science, the pathophysiology of reproduction, and the critical details about STIs.
Super important.
Third, we're going to shift our focus to the pillars of legal duty and essential screening across the human lifespan. And then finally, we'll wrap it all up with how the body handles pressure stress, coping, and sensory functioning. Are you ready to dive into this foundational material?
I am ready. Let's start by laying the ethical groundwork, because really you can't talk about health without acknowledging how deeply society influences who gets sick and, who stays well.
When we talk about health outcomes today, the language, it just matters so much. We hear terms like disparity and equity constantly, but they're often misused or used interchangeably.
They are.
Before we can even think about intervening, we need crystal clear definitions of the playing field.
Absolutely. For anyone who's entering clinical practice, this terminology literally dictates your ethical focus. So let's start with the big one. The definition set by Healthy People 2030 for health disparity.
Okay.
They define it as a health difference that is closely linked with social, economic, or environmental disadvantage.
Okay, so that qualifier is everything. It's not just any difference.
Exactly. Notice that crucial part. It's not just any difference, like, variations in height or eye color. It is a difference that is rooted in unfairness. It's rooted in systemic disadvantage.
That makes perfect sense. So a disparity is the observation. It's the measurable gap we can see. But the National Institutes of Health, the NIH, they help us organize where we see that gap, right?
That's right. The NIH kind of divides the problem into 2 observation points, which is really helpful. First, you have healthcare disparities. These are the observable differences in access to or the availability of facilities and services. So can you physically get to a clinic? Is that clinic any good? Is it high quality?
Right.
And the second one?
The second is health status disparities. This refers to the actual variation in rates of disease occurrence, like, say, diabetes or disabilities between different socioeconomic or geographic groups. It's the outcome.
Okay, so if those are the problems we observe, the access and the outcomes, what's the goal? What are we actually fighting for?
That is health equity. And health equity is the attainment of the highest possible level of health for all people. It's really the ultimate expression of social justice in health.
That meaning that the disparities we just talked about, they're gone.
They're gone. It means the absence of those disparities, or at least the avoidable differences. If we actually achieve equity, the outcome of your health should not be dictated by your zip code, your race, or your income level, period. Now we get to, I think, the powerhouse concept here, the social determinants of health. This really explains why the disparities we just defined even exist. If you're studying this material, this is where you grab your biggest virtual highlighter.
This is it. SDOH are the non-medical conditions where people are born, grow, live, work, and age. They are, quite literally, the entire context of a person's life outside the 4 walls of a hospital.
And critically, these are the factors that are mostly responsible for the health disparities we see.
They are. They drive the whole thing.
And here is the truly astonishing, high-impact piece of data that should shock everyone. Studies show that about 80% of health outcomes are determined by these social and environmental factors, not by the clinical care we provide.
It's a staggering number. It really is.
And of those SDOH factors, the vast majority are modifiable.
And that is the core takeaway. If you remember one thing, remember that. We are not talking about some fixed genetic destiny here. We are talking about policy choices, zoning laws, resource allocation, education access. We have immense power in this space. And when these factors are adverse, when, transportation is non-existent or housing is unsafe, the consequence is premature mortality, increased disease burden, and the breakdown of community health.
So to make this concept stick, let's visualize the 5 key pillars of SDOH. Imagine you are drawing a circular map of influence around a person. What are the 5 big forces that are constantly impacting their health?
Okay, great way to picture it. Number 1 is health and healthcare. This is pretty straightforward. It's the quality of care available and your ability to access it. Do you have insurance? Do you have a reliable primary care provider?
Okay, that's the one we usually think of. What's number 2?
Number 2 is the neighborhood and built environment. This is the physical world around you. Is your housing safe? Is the air and water clean? Is there reliable transportation? Are there even sidewalks to exercise on?
Right, things we take for granted.
Completely. Yeah. Number 3, social and community context. This involves your social support network. Do you have friends, family? It also includes levels of community safety and, crucially, freedom from discrimination.
Okay. Number 4.
Number 4 is economic stability. I mean, this is a huge one. Can you afford to live? This means employment, income, food security, and your ability to manage medical costs without going bankrupt.
And the last one.
Number 5, education access and quality. This profoundly impacts job stability down the line, and critically, it impacts health literacy, which we'll see is a life or death issue.
I want to zoom in on 2 of those that you just listed because they're so interconnected. Economic stability and food insecurity. When resources are low, people face these just terrible decisions.
It's the tragic choice, isn't it? It's the heat or eat dilemma, or medication or food.
Exactly.
And food insecurity, which is the lack of reliable access to sufficient nutritious food, it forces people to select high-fat, high-sodium, energy-dense foods.
Wow.
Why? Because they are the cheapest calories available.
And that has a direct line to disease.
A direct line. This immediately impacts chronic disease management, driving up rates of hypertension, diabetes, heart failure. It's an unavoidable outcome of a totally modifiable economic SDOH failure.
Okay, time for a high-yield material moment. We've established that nurses and clinicians must act on disparities, but where do you focus your energy? This framework of 4 categories, it helps you decide what's a normal variance and what's an ethical emergency.
Right. You have to be able to sort these out. You need to understand which disparities are unavoidable versus avoidable, and which are acceptable versus unacceptable.
So let's start with the easy one, unavoidable and acceptable.
This is the stuff we don't worry about from a policy standpoint. We see this in things like age. Older adults, just by nature of physiology, have more health needs and therefore higher rates of ER visits than children.
It's a natural biological process.
It is. Policy cannot and shouldn't try to fully eliminate that. We accept that difference exists.
Okay, so the next 2 categories are where the ethical mandate really comes in. We are most concerned with avoidable and unacceptable disparities.
These are the ones that should keep us up at night. These are systemic, policy-driven problems that can and should be prevented through targeted intervention.
Can you give us a strong example of that?
Sure. Our source material highlights a really clear disparity in cancer pain management between Asian populations and white populations. Studies show that Asian patients often receive less adequate pain medication.
And that's not biological?
Not at all. It's often due to cultural values, maybe education gaps, or a failure of the provider to adequately assess and educate on appropriate medication usage. This pain is unnecessary, it's unacceptable, and it's entirely avoidable with proper, culturally informed patient education. This is where nursing intervention is absolutely non-negotiable.
And then you have the most complex category, which is unavoidable and unacceptable.
Yeah.
This is where, nature and system failure just collide.
Yes. The classic example here is the high prevalence of type 2 diabetes in certain Hispanic populations. Yeah. There may be a partial genetic component, right, that makes the underlying risk to some degree unavoidable. But the unacceptable part is the systemic failure. The lack of affordability and availability of nutritious food, coupled with poor access to preventative diabetes screening and management programs. The system fails to mitigate an inherent risk.
So we treat the genetics as unavoidable.
But the system's failure to adapt to that reality is completely unacceptable.
The power of these SDOH concepts, it really hits home when we look at individual clinical failures. So let's spend some real time with these scenarios, tracing the thread from the social barrier right through to the patient's acute pathophysiology.
Let's do it. Let's start with Maria Gonzalez. She's a 58-year-old Spanish-speaking housekeeper. She has limited literacy, and she presents with newly diagnosed type 2 diabetes.
Okay.
So the clinic was busy, right? The usual story. They skipped arranging a certified interpreter. Instead, they relied on her 12-year-old daughter.
Oh, no.
And they handed Maria a stack of complicated English discharge instructions about her new medication, metformin.
Okay, stop right there. That's a huge, critical decision point. A NCLEX alert. Safety violation is flashing in big red letters.
Yeah.
Why is using the 12-year-old daughter so incredibly dangerous?
Well, first, it's a violation of patient privacy. But even more critically, it is a massive safety hazard. That child does not understand complex medical terminology like hyperglycemia or glucose monitoring or the precise mechanism of action for metformin.
She doesn't have the context for any of it.
None. So Maria went home. She experienced some common but totally manageable side effects, a little bit of nausea. And because she was never warned and she couldn't read the instructions, she just stopped the medication entirely.
And the result?
The result was a completely unnecessary readmission for diabetic ketoacidosis, or DKA, a life-threatening condition. Her language barrier, her limited education, and her job, which is her socioeconomic status. Those were the root causes, and they led directly to a provider's negligent act.
The failure to provide a qualified interpreter.
Exactly. That SDOH failure became an acute clinical crisis.
Wow. Okay, next case. Let's consider Dorothy Johnson. She's a 70-year-old patient with complex heart failure, HFrEF, and hypertension. She had a 6th grade education, and she would often just nod politely when specialists used words like diuretic and INR monitoring.
And she was terrified to admit she didn't understand a single word. Dorothy is the quintessential example of low health literacy.
So what clues should the nursing staff have picked up on immediately? What were the red flags?
Well, the limited formal education is a huge one. That should always be a flag for you to slow down and simplify. Her nodding, which seems like she's being cooperative, is often a sign of deep confusion and embarrassment.
She doesn't want to look foolish.
Nobody does. So when she was discharged, she simply couldn't navigate the complex regimen. She stopped taking her furosemide because the increased urination was inconvenient for her. She got her metoprolol schedule confused. And because of her economic stability issues, she relied on cheap, high-sodium canned soups.
Which is just pouring gasoline on the heart failure fire.
Absolutely. So she retained fluid, her heart struggled, and she ended up right back in the ER with acute decompensated heart failure, having gained 15 pounds of fluid in just 1 week.
And her inability to grasp the need for a 2-liter fluid restriction or consistent medication timing, all of that is tied directly to her literacy level, and it caused irreversible myocardial stress.
You can draw a straight line from low health literacy to pathophysiology. She couldn't understand the discharge instructions, which, by the way, directly links back to a potential breach of duty in the legal sense, which we're going to discuss later on.
Okay, let's move on to James Mitchell. He's a 45-year-old man living in rural Montana, 60 miles from the nearest clinic.
And that clinic operates Monday to Friday, 8 a.m. to 4 p.m., standard hours.
He works 2 jobs, he has no insurance, and he relies on an old pickup truck that often breaks down. He ignored some chest pressure for 6 weeks because he was afraid of the lost wages and the cost of the trip.
James's health failure is defined by geography, transportation, and economic stability. That 60-mile drive and the Monday to Friday 8 to 4 clinic schedule are massive structural barriers. When you don't have paid sick leave, missing work for a, quote, non-urgent checkup feels impossible.
And the tragic outcome was a massive STEMI, a major heart attack that caused significant, irreversible cardiac damage.
And he had undiagnosed, completely modifiable risk factors that preventative care, that secondary screening, would have caught easily.
Like what?
Uncontrolled hypertension, dangerously high cholesterol, and prediabetes. James shows us that system failure, not biology, can cause a heart attack just as surely as a massive clot can.
Wow. Okay, and finally, we have to reflect on the case of Alex Torres, a 32-year-old transgender man who experienced horrific discrimination in past healthcare encounters.
I mean, just awful stuff. Dead naming, misgendering, invasive, irrelevant questions. So he avoided care for 5 years because of this trauma.
And when he finally sought help for abnormal bleeding, the provider incorrectly told him he didn't need a pap smear because he presented as male.
That is just. It's a heartbreaking and completely unacceptable knowledge gap. That provider's bias, their failure to screen based on the patient's anatomy, their assigned sex at birth rather than their gender identity, resulted in a stage IIB cervical cancer diagnosis when he finally got the right care.
So this case really encapsulates how discrimination and bias are lethal social determinants of health.
They absolutely are. They erode trust, they lead to avoidance of necessary screening, and they cause delayed diagnosis, turning a treatable condition into a life-threatening one. The ethical mandate to provide non-discriminatory, informed care is a fundamental component of reducing this kind of disparity.
Okay, let's pivot now from the macro environment of policy and society to the micro environment of the human body, specifically the intricate system of reproduction. Time for a quick anatomy and pathophysiology refresher on our virtual whiteboard.
Let's do it. To start simply, just remember the reproductive system has two main jobs, and those are carried out by the primary organs, or the gonads.
The testes and...
Exactly. They secrete the necessary hormones, and they produce the gametes, the sperm, and the ova.
And then the secondary organs are really just the accessory systems that handle everything else. Transport, nourishment, protection. You can think of the uterus as the ultimate protective chamber, or the fallopian tubes as the transport highways.
Perfect analogy. And the timing of gamete creation, what we call gametogenesis, is fascinatingly different between the sexes. Spermatogenesis starts at puberty and is continuous throughout the adult male's life, happening in the seminiferous tubules.
But for females, it's a completely different story.
A completely different timeline. For females, oogogenesis begins during fetal life. The eggs are already there, but they don't fully mature and begin their cycle until puberty starts.
So let's track that cycle. Let's track the famous 28-day clock, which is the body's monthly preparation for a potential pregnancy.
Yeah.
This is a complex, carefully choreographed feedback loop involving the hypothalamus, the anterior pituitary gland, and the ovaries.
It's a beautiful system, and we can break it down into 4 key stages that are driven by 4 key hormones.
Okay, stage 1.
Stage 1, the menstrual phase. Basically, the previous cycle failed to result in a pregnancy. So estrogen and progesterone levels bottom out, and this hormonal drop signals the shedding of that thick uterine lining, the endometrium. That's the menstrual bleeding.
And after that, we rebuild.
We rebuild. That's stage 2, the follicular phase. The brain starts releasing FSH, follicle-stimulating hormone, which recruits a follicle in the ovary. That follicle starts producing rising levels of estrogen, which prepares the ovum and starts thickening the uterine lining all over again.
Which leads to the main event.
The main event, stage 3, the ovulation phase. This is the climax of the cycle. The high estrogen level triggers the anterior pituitary to release a massive surge of LH, luteinizing hormone. This LH surge is the key. It causes the follicle to rupture and the ovum to be expelled.
And finally, stage 4.
Stage 4, the luteal phase. The ruptured follicle that's left behind transforms into the corpus luteum, and its only job is to pump out large amounts of progesterone. This makes the uterine wall even thicker, spongy, and nutrient-rich, just patiently waiting for a fertilized egg to implant.
And if that doesn't happen...
If implantation doesn't occur, the corpus luteum degenerates, progesterone levels crash, and the whole cycle resets right back to stage I.
It really is a fascinating dance between the brain and the ovaries.
It is.
Okay, moving to contraception. We should first distinguish the non-prescription methods. So abstinence is obviously 100% effective. And barrier methods like condoms are critical because they're the only method besides abstinence that offers effective dual protection.
Dual protection against both pregnancy and STIs. That's a huge point.
It is. So now for the hormonal methods. Understanding the pathophysiology here is really the key to safe practice.
It is. The goal of hormonal contraception is to basically manipulate that menstrual cycle we just discussed to achieve 3 things all at once.
Okay, what are they?
You want to stop ovulation, thicken the cervical mucus to make it impenetrable to sperm, and thin the uterine lining to make implantation impossible, even if fertilization somehow occurred.
So how does the hormone actually stop the process? What's the mechanism?
Let's break down the role of the 2 primary synthetic hormones. First, estrogen, usually ethinyl estradiol. It acts high up in the system. It inhibits the formation of the dominant follicle, which means the ovary never fully matures an egg.
Okay.
But most critically, it prevents that necessary high LH surge from happening. And if there's no LH surge, there's no stage 3. There's no ovulation. End of story.
Okay, so that's estrogen's job. What about the other player, progestin?
Progestin, which is the synthetic progesterone, is a multitasker. It also helps suppress the LH surge, just like estrogen, but its physical effects are the most notable. It dramatically thickens the cervical mucus. I mean, imagine putting heavy tar in the cervix to trap sperm.
What a visual.
Right. It also makes the uterine lining hostile to implantation and even slows the movement of the fallopian tubes, which prevents the ovum from being transported. It provides contraception on its own, and it balances estrogen's side effects.
And we primarily see these two hormones combined in CHCs, combined hormonal contraceptives. They come as pills, patches, or the vaginal ring. And while the benefits are great predictable cycles, reduced cancer risk, there is a massive critical decision point we have to address.
Yes, and that is the VTE, venous thromboembolism risk, the risk of blood clots.
And estrogen is the culprit here.
Estrogen is the culprit. Pathophysiologically, estrogen creates a hypercoagulable state. It does this by increasing certain clotting factors in the blood while at the same time decreasing the body's natural anticoagulants. It just tips the balance toward clot formation.
Which means we cannot dispense CHCs blindly. We have to screen for high-risk patients. Who is absolutely contraindicated for these?
Anyone with an elevated risk of clotting. This list includes women aged over 35 whose smoking adds enormous vascular risk. Anyone with a personal or immediate family history of VTE, patients with uncontrolled high blood pressure, or patients with diagnosed inherited clotting disorders like factor V Leiden mutation.
So if any of those risks are present,
You must choose a progestin-only method that completely eliminates the estrogen-related VTE risk. It's a critical safety check.
that's a powerful differentiation. Speaking of progestin-only methods, the depot-medroxyprogesterone acetate injection, or Depo-Provera, is very popular. It gives you flexible dosing every 11 to 13 weeks and usually leads to amenorrhea, which is no period.
It's very effective, yes, but it has a completely unique pathophysiology alert that you have to know. Because DMPA suppresses FSH and LH so thoroughly to prevent ovulation, the body's own estrogen production drops dramatically. It basically mimics menopause.
And what does that low estrogen state do to the body?
This greatly decreased estrogen level causes a decrease in bone mineral density, BMD.
So the body starts pulling calcium out of the bones. What is the mandatory nursing intervention here? What do you have to teach?
The mandatory teaching must include supplementing with calcium and vitamin D and encouraging regular weight-bearing exercise. We have to actively counter the physiological effect of that low estrogen state to protect the patient's long-term skeletal health. This requires ongoing education and monitoring.
The final part of this segment it's pretty sobering. STI rates in the U.S. are at an all-time high. They affect nearly 1 in 5 adults. It's a public health crisis driven by high-risk behaviors, socioeconomic factors, and frankly, decreased consistent condom use.
The risk factors are very clear. Multiple partners, inconsistent barrier use, and substance use, because alcohol and drugs often impair judgment. Also, just having one STI means you are more vulnerable to getting others because the infection site is already compromised.
And before we talk about specific pathogens, let's flag a key professional duty: mandated reporting. This is a must-know fact.
It is. Nurses are legally required to report all diagnosed cases of gonorrhea, syphilis, and chlamydia to public health authorities. This isn't optional. This allows for contact tracing and helps control outbreaks.
Okay, let's start with the bacterial and therefore curable infections. Chlamydia is the most frequently reported bacterial STI. The really tricky part is that it's often completely asymptomatic, especially in women.
A silent infection.
But the complications are very serious. If it's left untreated, it can cause pelvic inflammatory disease, PID, in women, which can lead to chronic pelvic pain, infertility, and a dramatically increased risk of an ectopic pregnancy.
And the treatment is often doxycycline. Now, this comes with a long list of specific essential teaching points. This is a major NCLEX treatment alert.
Let's hear them.
Doxycycline must be taken on an empty stomach to ensure absorption. Patients have to avoid dairy products, antacids, or iron supplements for several hours around the dose, as these will bind the drug and make it useless.
Okay, what else?
Patients need to remain upright for 30 minutes after taking it to prevent esophageal irritation. They must avoid prolonged sun exposure due to photosensitivity. And finally, it is contraindicated during pregnancy.
That's a lot to communicate effectively, which connects right back to our health literacy discussion with Dorothy.
It really does.
Okay, next up, gonorrhea, the second most common. We hear a lot about resistance being a growing global problem.
It is, which is why the first-line treatment for uncomplicated cases is now often a single, high-dose intramuscular injection of ceftriaxone to try and overcome that resistance.
And finally, for the bacterial protozoan group, we have trichomoniasis, or TRICH, caused by a protozoan. Treatment is metronidazole or Flagyl. And here is the famous classic NCLEX treatment warning.
Ah, yes, the one about alcohol.
Exactly. Why is that specific warning so severe?
Metronidazole interacts with alcohol to cause a severe, violent disulfiram-like reaction. The patient experiences intense nausea, projectile vomiting, severe flushing, headache, shortness of breath. It's miserable.
So what's the specific instruction?
You must educate the patient that they have to abstain from all alcohol use, and that includes products with hidden alcohol like certain mouthwashes or cough syrups, while on the medication and for a minimum of 24 hours after the last pill, no exceptions.
Moving on to the viral infections, which are lifelong but treatable. Let's start with genital herpes, HSV 1 and 2.
Right. So the virus enters the skin, it reproduces, and it causes these painful vesicles that rupture into ulcers. While the disease is incurable, the really interesting thing is that transmission is actually most common during periods when the patient is asymptomatic due to something called viral shedding.
And there's a huge pregnancy safety alert for herpes. It's vital.
Absolutely critical. If a mother has any active genital lesion at the time of labor, she requires an emergency C-section.
Why?
The risk of vertical transmission to the baby is extremely high if the infant passes through the infected birth canal, and it can lead to devastating neurological damage or death. So suppressive antiviral therapy, usually valaciclovir, is started routinely around 36 weeks of gestation if there's a history of recurrence to try and prevent an outbreak near delivery.
Okay, next viral one. Genital warts caused by the human papillomavirus, or HPV. There are over 150 types. Some are low risk and just cause warts, but the high-risk strains.
The high-risk strains are notorious for causing cancers: cervical, anal, and oropharyngeal.
So the treatment for the warts is just physical removal, but that doesn't actually clear the virus itself.
Right. The true power here lies in primary prevention, the HPV vaccine. It protects against the strains that are responsible for 90% of those cancers and warts. It's recommended for ages 11-26, ideally before the onset of sexual activity. This is one of the most powerful cancer prevention tools we possess.
Finally, let's wrap this section up with syphilis, caused by the bacterium Treponema pallidum. It's famously nicknamed the Great Imitator. Why that nickname?
Because its symptoms are so vague and they mimic dozens of other diseases, making it incredibly tricky to diagnose if you aren't actively thinking about it and screening for it. The disease progresses in stages, and a patient may not even realize they're infected.
So, briefly walk us through the path of the disease.
Sure. Primary syphilis is marked by the presence of a painless but highly infectious sore called a chancre at the site of entry. This sore heals on its own after a few weeks, which makes people think they're fine.
But they're not.
Not at all. Secondary syphilis follows. It's still highly infectious, and it causes systemic symptoms, a flu-like illness and a non-pruritic or non-itchy rash that characteristically appears on the palms of the hands and the soles of the feet.
And if it's still untreated, it moves into the silent latent stage, which can then progress years later to tertiary late syphilis.
And this is the stage of systemic destruction. You get inflammatory tumor-like lesions called gummas, cardiovascular damage, and neurosyphilis, which affects the central nervous system. The good news is the treatment is powerful, simple, and effective for early stages.
Which is?
A single dose of penicillin G benzathine administered intramuscularly. And just like the other reportable STIs, all sexual contacts from the preceding 90 days must be urgently evaluated and treated.
We've seen the systemic failures with James and Dorothy and the micropathology of disease. Now let's talk about the system that's built to prevent those failures, the legal duties that bind us as professionals, and the proactive screening strategies we use.
Right. Nursing is a high-stakes profession. It demands critical thinking, accountability, and patient-centered care. And when that care falls short, the legal system often steps in, primarily through what are called torts.
So what is a tort?
A tort is just a civil wrongful act or an omission of care that's made against a person or their property.
And the two terms we really need to nail down are negligence and malpractice. They're related, but not the same.
Exactly. Negligence is the baseline. It's conduct that simply falls below the accepted standard of care that a reasonably prudent person would exercise. Malpractice is simply a type of negligence, specifically where the person who's held liable is a professional, a doctor, a nurse, a therapist.
And this is a massive NCLEX alert, the 4 elements of negligence. A malpractice case is not successful unless the plaintiff, the person suing, can definitively prove all 4 of these elements. This is the legal burden of proof. You have to know this checklist.
You do. Number 1, a professional duty owed to the patient. Did a nurse-patient relationship exist? Were you responsible for their care? That's usually easy to prove.
Okay, number 2.
Breach of duty. Did the nurse fail to carry out that duty? Did your conduct fall below the accepted standard of care?
Number 3.
Causation. Was the patient injured? Did they suffer physical, emotional, or financial damage?
And the final one, which links it all together.
The injury resulted from the nurse's breach of duty. Was there a direct, traceable link between the breach of the standard of care and the injury that occurred?
So if we tie this back to Dorothy Johnson, the heart failure patient who stopped her meds and ended up readmitted, where is the potential negligence in her case?
The hospital or the nurse may have failed the breach of duty element, specifically through failure to convey discharge instructions effectively.
How so?
Well, if the standard of care requires teaching at a level the patient can actually understand, using things like the teach-back method, simplified materials, and the nurse instead just hands complex jargon to a patient with sixth-grade literacy.
Then that failure to meet the standard of care, the breach of duty, directly caused her injury, which was the acute decompensated heart failure and the readmission.
Precisely. Other common negligent acts we have to rigorously avoid are failure to assess or monitor unstable patients, failure to use proper equipment like restraints or lift devices, and of course, critical failures in medication administration, the six rights.
So reducing legal risk really means constant documentation, strict adherence to facility policy, and proactive risk management.
All day, every day.
Okay, let's shift our focus now to proactive prevention. We can visualize this as 3 tiers or levels of defense.
I like to think of this like gardening. Primary prevention is the foundation. It aims to prevent the disease from ever occurring. You are planting good seeds, building barriers.
So examples would be the HPV vaccine, mandatory seatbelt use, or nutritional counseling before any disease sets in.
Exactly. Now, secondary prevention is the next tier, and it's the main focus of this segment. This is all about early detection and screening. You are actively checking for pests before the plant shows any visible distress. The goal is to identify diseases in their silent, nascent stages, allowing for early intervention to stop the progression.
And finally, tertiary prevention.
That's managing the situation after the blight has already hit. It focuses on enhancing the quality of life and minimizing the impact of an existing chronic condition. This would be cardiac rehabilitation programs after a heart attack or strict adherence to a diabetes medication regimen to prevent kidney failure.
So let's put this secondary screening into practice, starting with the youngest patients. A major pediatric concern is lead exposure.
It is. Screening for this involves a simple risk assessment at well-child visits for children from 6 months to 6 years of age. Lead is just devastating because it irreversibly affects the developing brain, leading to permanent cognitive and attention deficits. We have to assess environmental risks. Is the house old? Is the paint chipping?
And if envision, screening is crucial by age 6. We are looking for conditions like strabismus, where the eyes are not properly aligned. Why is that specific age cutoff so important?
It's a critical window. If strabismus isn't corrected by age 6, the brain starts receiving 2 conflicting images, and it eventually just decides to ignore the weaker eye completely. This leads to amblyopia, or lazy eye, which is the most common cause of vision loss in children.
So early detection is key.
Early detection with patching or surgery is essential to force the brain to use both eyes before that visual pathway becomes permanently damaged.
We measure visual acuity using the Snellen chart. If a child has 20/40 vision, can you break down what that means in a conversational way?
Sure. Think of it as efficiency. At 20 feet away, that child can only see clearly what the average, normally sighted child could see from 40 feet away. Their vision is just less efficient. The goal of secondary screening and corrective lenses is always to bring that efficiency back to 20/20.
Okay, moving to the skeletal system, scoliosis screening is a quick visual test.
It is. We're just checking for a lateral curvature of the spine. Screening is usually recommended for girls around ages 10 and 12, and for boys at 13 or 14. We're looking for unequal shoulder heights or asymmetry of the scapulae, particularly when the child bends over. Early detection allows for bracing or other interventions before the curve progresses too far.
And shifting to adolescence, mental health screening is now, thankfully, non-negotiable. The USPSTF recommends screening for anxiety in children 8 to 18 and for depression in teens 12 to 18.
And the standard tool for depression screening is often the PHQ-2. It's incredibly efficient. It's just 2 questions.
What are they?
Over the past 2 weeks, how often have you been bothered by 1, little interest or pleasure in doing things, and 2, feeling down, depressed, or hopeless? If the answers are positive, that warrants a deeper dive using the PHQ-9 and a full clinical assessment. This is secondary prevention aimed at avoiding tertiary or crisis intervention.
For adults, let's focus on the silent killers, starting with blood pressure. Screening is recommended every 3 to 5 years for low-risk adults 18 to 39 and annually for anyone 40 or older or who is considered high risk.
But the accuracy is so crucial. This is a critical decision point in clinical practice. We have to avoid the common pitfalls.
Like what?
A patient talking during the measurement, a patient's arm hanging unsupported below the level of the heart, or, shockingly, a full bladder alone can artificially increase the systolic blood pressure reading by up to 33 millimeter Hg.
Wow, that's a huge error.
It's massive. If we measure incorrectly, we might start treating a patient for hypertension they don't have, or we could miss a real crisis due to inconsistency.
Then we have blood markers. Cholesterol and triglyceride screening starts around age 20 for low-risk adults, checking every 4 to 6 years. We're aiming for an optimal LDL-C, the bad cholesterol at or below 100 milligdl.
And a key teaching point that many people miss is the link between sugar and lipids. A high intake of sugar, especially from sugary drinks, is a massive contributor to high triglycerides, which significantly increases cardiovascular risk. It's not just the fat you eat, it's the simple carbs and sugars you consume.
Let's spend some significant time on cancer pathophysiology and the screening that saves lives. First, just defining the enemy. A neoplasm is simply a mass of new tissue that's growing without a physiological purpose.
Right, and we distinguish between two major types. Benign growths are usually slow, encapsulated, orderly, and non-migratory, which makes them easy to remove. Malignant tumors cancer are the aggressive kind. Pathophysiologically, these cells demonstrate indiscriminate and continuous division. They just violate the body's rules.
And one of the biggest rules they break is apoptosis, or programmed cell death.
Exactly. Cancer cells ignore the signal to die. They are rarely encapsulated, they adhere loosely to surrounding tissues, and critically, they are able to migrate through the process of metastasis to invade other parts of the body. They are anarchists, and their aggressive nature is why secondary screening is so vital.
To help the learner remember the clinical warning signs, we rely on the classic mnemonic. This is a crucial, must-know fact. Caution UP.
Let's run through it.
Change in bowel or bladder habits. Is it different than usual?
A lesion that does not heal. A persistent ulcer or sore.
Unusual bleeding or discharge.
Thickening or a lump. In the breast, testicle, or anywhere else.
Okay, keep going.
Indigestion or difficulty swallowing.
Obvious change in a wart or mole. That's the ABCDE rule.
A nagging cough or persistent hoarseness.
And the last two.
Unexplained weight loss.
Pernicious anemia.
Now for specific cancer screenings, starting with the deadliest. Lung cancer.
Annual screening via low-dose CT is recommended for adults 50 to 80 who have a 20-pack-year smoking history and either currently smoke or quit within the last 15 years. Smoking is responsible for a staggering 90% of cases.
For cervical cancer, the screening guidelines have become more nuanced, relying heavily on HPV testing now.
That's right. For ages 21 to 29, the traditional cytology, or PAP test, is recommended every 3 years. But for ages 30 to 65, the preference is shifting to screening every 5 years using high-risk HPV testing alone or co-testing HPV and cytology combined. The goal is catching those early cellular changes driven by the virus before they become cancer.
We must also mention skin cancer screening. The gold standard for self-examination uses the ABCDE rule for detecting melanoma.
Right. Asymmetry, irregular border, multiple colors, diameter larger than 6 millimeter or a pencil eraser, and evolving any change in size, shape, or color. This is secondary prevention, but the primary prevention, sunscreen SPF 30+, and avoiding tanning beds remains the most important defense.
And finally, colorectal cancer screening. The USPSTF now recommends starting at age 45, though risk factors like lack of physical activity, low fiber, high-fat diets, and alcohol or tobacco use can necessitate earlier screening.
Right.
Okay. We've saved the essential core of holistic care for last. How the body handles physical and emotional stress, and how we interact with the world through our sensory systems.
Right. And stress. Stress is simply the body's response to any actual or perceived threat to its normal state, its homeostasis. We have to differentiate between eustress, which is positive stress like excitement for a presentation, and distress, which is negative, overwhelming, and unmanageable stress.
And the physiological response to stress is predictable and powerful. It's known as the General Adaptation Syndrome, GAS, which is a 3-stage process.
It is. Stage 1 is the alarm stage, or fight or flight. The system goes online instantly. The hypothalamus releases CRH, which stimulates ACTH, and that floods the body with epinephrine and norepinephrine. Heart rate spikes, pupils dilate, resources are diverted to the major muscles.
Then what happens?
Then you enter the resistance stage. The body tries to stabilize. It maintains this state of heightened arousal, resisting the stressor while attempting to return resources to normal function.
But it can't do that forever.
It can't. If the stressor continues indefinitely, you hit the exhaustion stage. The body's compensatory mechanisms fail, Resources are depleted, and the system starts to break down.
And this breakdown has a specific name that is really crucial to know: allostatic load.
Yes, allostatic load is the cumulative, chronic wear and tear on the body's organs from continuous excessive stress. I like to think of it like constantly running your car engine at redline. Eventually, the components are going to fail.
And this chronic arousal contributes directly to real diseases.
It does. Things like depression, high blood pressure, diabetes, and autoimmune diseases. It is the physiological cost of living under chronic stress.
When patients face this, they use coping strategies. We need to distinguish between two main approaches, right?
We do. The first is problem-focused coping. This aims to directly resolve the problem that is causing the stress. If your stress is a massive to-do list, your coping is setting priorities and making a plan. You use this when the situation is controllable.
And the second approach?
Is emotion-focused coping. If the stressor is uncontrollable, say the death of a loved one, you can't solve that problem, so you focus on managing the feelings associated with the stress.
Yeah.
Taking a warm bath, venting to a friend, meditation. Both are essential, just for different situations.
Okay, let's talk about sensory alterations. Our whole world experience relies on normal sensation.
It does. It's a three-step process.
Right.
First, reception, where the stimulus creates an impulse. Second, perception, where the brain interprets that impulse. And third, reaction, where the body responds appropriately. When this breaks down, we see alterations.
And we recognize 4 key categories of sensory alteration, which are crucial in a care setting.
Right. First, sensory deficits, which is just a loss of normal function, like hearing or vision impairment. Second, sensory deprivation. This is a reduced sensory input, often seen in restrictive environments like isolated hospital rooms or when patients are heavily bandaged. This can lead to hallucinations or severe boredom.
And the opposite of that is?
Sensory overload. The inability to filter or selectively ignore multiple stimuli. Just imagine the noise, the lights, the alarms, and all the procedures in an ICU. The system is just completely overwhelmed.
And the last one is a newer concept.
It is. It's called sensory poverty. It's the idea of learning about the world through technological screens without ever experiencing it firsthand.
For the care setting, especially in the ICU, managing sensory deprivation and sensory overload is vital.
Absolutely. If a patient is overwhelmed, the nursing intervention is to reduce noise, dim the lights, schedule rest periods, and simplify communication. If they're deprived, we do the opposite. We actively increase stimulus, open the curtains, play some music, or allow visitors.
Let's focus on 2 specific sensory conditions that commonly affect older adults, starting with the eye. We have to discuss glaucoma. Pathophysiologically, what is happening inside the eye?
Think of the eye's fluid system like a kitchen sink. You have inflow, that's aqueous production, and you have outflow, which is reabsorption. Glaucoma is a group of disorders where that balance is lost because the aqueous production is greater than the aqueous reabsorption. The plumbing gets backed up.
And the consequence of that increased fluid, that backed up plumbing?
It creates increased intraocular pressure, IOP. Normal IOP is between 10 and 21 millimeter Hg. When this pressure rises, it puts a relentless strain on the optic nerve, causing irreversible damage and classically peripheral visual field loss.
And this loss is silent, isn't it?
It's silent and it's slow, which is why screening is so important. Patients often don't notice it until severe permanent damage has already occurred.
Contrasting that, we have age-related macular degeneration, AMD.
Right. If glaucoma makes you lose your side vision, AMD makes you lose your central vision. It's the leading cause of irreversible central vision loss. It affects your ability to read, to drive, to see faces.
And a critical diagnostic tool here is the Emsler grid test.
Exactly. It helps patients detect if the lines in their central visual field appear wavy, distorted, or missing. It's like a hole in the center of a photograph.
Now, for an absolute NCLEX alert, ocular emergency, what symptom requires immediate emergent care?
Retinal detachment. This is the physical separation of the retina from the underlying nourishing layer. It requires immediate surgery to seal the breaks and reattach the retina before the photoreceptors die from lack of oxygen.
And the signs are easy to remember because the patient will tell you what's happening.
They will. They report sudden flashes of light, photopsia, an increase in floaters, or the dramatic sensation of a curtain coming across the visual field. This is an irreversible, time-sensitive crisis. You have to act fast.
And finally, shifting to the ear, let's look at presbycusis.
This is the age-related sensorineural hearing loss. It's caused by degeneration of the inner ear.
And it's not just that things sound quiet, right? It affects specific sounds.
Yes, that's the key. Often it's the inability to hear high-frequency sounds. This means they can hear the low-frequency vowels, but they struggle severely to distinguish the high-frequency consonants, which leads to confusion and social isolation.
And a simple but often missed nursing tip before we conclude.
Always, always, always check for the presence of impacted ceramin or earwax before you assume it's sensorineural loss in an older adult. Ceramin impaction is a very common cause of temporary, easily treatable conductive hearing loss. You might solve a major communication problem with a simple irrigation.
That was an incredible sweep through the foundations of clinical knowledge. We started with the immense pressure exerted by society, the poverty of James, the bias facing Alex, the literacy issues of Dorothy, and then we traced how those external factors led directly to irreversible internal damage.
Yeah, whether that was a STEMI or a stage IB cancer.
And the essential pattern for you, the learner, to recognize is that powerful connection between the social determinants and the resulting pathophysiology.
It is. Dorothy Johnson's low health literacy, the SDOH, caused her medication non-adherence, which resulted in acute decompensated heart failure, the pathophysiology. This is the level of critical thinking you absolutely must master. We have an ethical and professional mandate to address these avoidable and unacceptable disparities.
And we ended this deep dive by discussing positive coping strategies, specifically problem-focused coping, finding direct, achievable solutions to the source of the stress.
So we want to leave you with this provocative thought. We know that non-medical conditions, the social determinants of health, are the biggest stressors driving poor health outcomes in our communities. We discuss how James Mitchell was blocked by geography and transportation.
Right.
So how can future healthcare professionals apply that problem-focused coping approach, finding tangible solutions like mobile clinics or evening hours, to truly begin fostering health equity, rather than just treating the resulting symptoms that walk through the ER door?
A great question to keep turning over. Until next time, keep digging deep and keep learning.